There's so many ISPs that we see that we can't even think of it. Right.
Who is John Yohanan?
I know, well, I had an MRI, a thoracic MRI before I left, and my back surgeon said, I don't see any concussion, I don't see any fractures, I don't see any this. Well, it's good in the sense that she doesn't see anything, but in the meantime, I can't walk, and the pain is so there. No, so you know what it's like. I know, yeah. But I do have a doctor here
This is gold, and we just sort of have to work on some teaching level. It's funny. Yes, that's it. So, should make sure that we don't have those end of days, like said, that's like. All right.
Good evening, everyone. Thank you all for being here. I'll go ahead and get us started. I'm Sonia Fiddler. I'm the president here at Yampa Valley Medical Center. Thank you all for joining us. We're really excited to have you all here and have this opportunity to hear from our experts around managing back pain tonight. So thank you again for coming. So prior to the pandemic, we used to have these events quite often. They were always well attended and I think really beneficial for our community. During the pandemic, we actually had a few of these that we held virtually and continue to see the demand for this type of topic and making sure that we're educating our community around your health. And so I'm really excited the fact that we're back up and running and back in person and can continue to provide this opportunity for you all. So it's really great to collaborate with Steamboat Orthopedic and Spine Institute, otherwise known as SOCI, in order to provide this type of community event. And we hope that this is just the start of us being able to continue to provide these. And of course, we'd love to hear from you all too on topics that you want to hear about and for us to focus on. So thanks. I do want to take a moment to thank all the individuals that helped put this together. It does take a lot of work, as you can imagine, as little as microphones and IT and seating. And so there's a lot of different groups and team members that come together to help us pull this off. So thank you to all of them. And again, thank you for being with us tonight. So I am going to share.
I'll let the IT guy. He's got a good barber, right?
Great. Usually I have a loud enough voice, so I don't need these microphones. But just a few housekeeping reminders. If you can turn your cell phones on mute or on silent or turn them off, that would be great. The event is actually also streaming virtually, so we have a virtual audience, and this discussion is being recorded. So just so you're aware of that. In the room, if you have any questions, please raise your hand during the event, and we have microphone runners that will come to you with a microphone. If you're on the virtual setting, please add your question in the chat function, and we have someone monitoring that. Also, if you're virtual, please make sure you're on mute. And then we are seeing a lot of faces on the camera, and if you all choose to not turn on your camera, it will allow our presentation to be bigger in a view for you all on the virtual setting. So we can't see you, so I don't think the camera is useful. So if you can turn off your camera, then, and if everyone can turn off their camera, then you'll see the presentation in a better view. I think I got all the housekeeping reminders. Okay, so now I'm going to hand it over to Forrest Pekka, who is the SOCI's Clinical Outreach Director, who's going to introduce our wonderful speakers for tonight. Thanks again for coming.
Thank you, Sonia, and let's give her a big round of applause. What an amazing lady. She's really done so much here in the Valley and really created exceptional healthcare. So we're really proud of her. Really happy to be working with UC Health on these talks. So I want to introduce our speakers for tonight. We have Dr. Lynn Tyson Sloan, which is no relation to Lynn Swan, but he goes by Tyson. Dr. Sloan earned his medical degree in osteopathic medicine in Knoxville, Tennessee. He completed his residency in physical medicine and rehabilitation, PM&R, at Baylor University in Dallas, Texas. Dr. Sloan joined the Sosi family approximately 1 year ago, coming from Las Cruces, New Mexico. Dr. Sloan specializes in non-operative management of spine disorders and takes special interest in working through diagnosis of the most challenging spine pathologies. Dr. Sloan and his lovely wife, Rebecca, who just happens to be an RN with us at Sosi, have 4 children, ages 7, 11, 13, and 15. If you don't find Dr. Sloan enjoying the outdoors, fishing, hunting, and camping, you'll likely find he and his family at either Howelson or Steamboat enjoying the slopes. After that, we're going to have David, Mr. Dave Grinnell. Dave completed his undergraduate degree at Hope College in Michigan and earned his clinical doctorate in physical therapy at Bellarmine University in Louisville, Texas. He then went on to complete a post-professional physical therapy residency in orthopedics at the University of Utah. Dave has been a stalwart here in Steamboat, arriving in 2013. And if you haven't been treated by Dave, you might have seen him on the slopes, skiing in the winter, mountain biking in the warmer seasons, repping soccer, or just enjoying the outdoors. But fun fact about David is he qualified for the Boston Marathon. How about that? Our final speaker is going to be Dr. Alex Saladicki. Just as an FYI, Dr. Saladicki is finishing a surgical case right now, why he's our last speaker, and he'll be coming here as soon as he's done with the case. But he was recruited to join Sosi from Dr. Clint Devon, completed his medical school at Penn State University, College of Medicine, followed by orthopedic residency at Vanderbilt University. And then 2 years ago, Dr. Saladicki and his family came to join Sosi via Chattanooga. So if anybody's familiar with Chattanooga and you've seen the Rock City red birdhouses, maybe a few, maybe not, but welcome to Chattanooga and Rock City. But Dr. Saladicki specializes in complex spine surgery and spine motion preservation. He, as many steamboaters, enjoy the outdoors. He can rip skiing. I was able to go skiing with him last week. And when not, he's chasing his 4 children, ages 7 weeks, 2, 4, and 5.5. So a little bit younger than Dr. Sloan here. His wife doesn't work at Sosi. However, she could be a patient, just like the Hair Club for Men, right? So we want to thank you all for coming to Sosi and UC Health Community Talk here. With that, please welcome Dr. Tyson Sloan.
Can everybody hear me? Sounds good? All right. Well, thanks for coming out. It's a pleasure to be here. But we'll kick things off talking about the back and the neck. Now, you're going to hear me say the word back a whole lot. You probably won't hear me say the word neck a whole lot. Okay. If you have neck pain and you're more interested in neck, every time you hear the word back, just think neck. Okay. We do a lot of similar things with the back. And the neck, okay? It looks a little different, but there's the principles and a lot of the treatment we do are very, very similar, both neck and back, all right? So just kind of moving on here. Possibly.
Got it.
Oh, okay, there we go. All right. All right, so basically, low back pain is insanely common, okay? So basically, the most common complaint a primary care doctor is going to get is musculoskeletal pain, an aching pain somewhere. And usually the most common aching pain location is going to be the back or the neck. It's going to be somewhere in the spine. So incredibly common, okay, to have those aches and pains. So just to go over a little bit about the back, okay, and the anatomy of the back, so we have a basic understanding of what's going on here. In the back, you have the bones, okay, or I should say spine, okay, you have the bones that are stacked on top of each other. In between the bones, you have the discs, okay. Discs are basically cushions in between the bones so that you can move. Otherwise, it would be one solid bone, and we're not very bendy if we're all one solid bone going through our body. So those discs help provide movement, okay. At every level in the spine behind those discs are little spaces, okay? And you have them on both sides. And out of those spaces run nerves, okay? And those nerves run down into our body and they help control our body, help sensation in the body, move our muscles, all of those things that we do every day and we take for granted, we don't even think about it, all leave in the spine here, okay? And then further back, you have the joints in the back, right back here where the bones come together, okay? So that's some of the basics of the back right there. Okay, so moving forward and talking a little bit more about the disc, which is a very common culprit when it comes to pain in the neck or the back. There's two parts to the disc. There's the inside part of the disc, okay, has a lot more fluid to it. Actually, if you go into surgery and you take it out, it looks a little bit like crab meat. Okay, interesting little fact there. Okay, but that inside part of the disc, what helps absorb the pressure of your daily activities when you go running, walking, going through the powder up on the hill. Okay, that's what absorbs the pressure, and it's surrounded by a tough, hard ring. Okay, the job of that ring is to keep that cushion part inside where it belongs, keep it nice and healthy and happy. Okay, so what can happen with these is you can get a disc herniation. So you may hear some of these terms thrown around: herniated disc, slip disc, bulging disc, extruding disc. Slip disc, okay, discs don't really slip. That's more of a layman's term, really, okay? But what they do is they can herniate, they can bulge, and they can extrude. There's some small differences for that. But I'll tell you, a lot of doctors, radiology reports, things like that, they'll throw around herniated and bulging disc interchangeably, okay, even though there's some slight differences. Extruding is kind of more to the extreme of a disc herniation, okay, so to speak. So let's talk a little bit about these here. So this is an MRI of the back, okay? Sometimes I'll get some patients, they'll have an MRI or a CAT scan or something like that, and they'll go, oh my gosh, the report said I had a disc bulge, this is so bad, okay? That's not necessarily true. Not all herniations are created equal. In fact, the way I like to explain it is I can take 100 people who have zero back pain whatsoever. Their backs are doing great. I can get an MRI on all 100 of them, and probably 70 to 75 of them are going to have some type of disc bulge or disc herniation. Okay? They don't even know it. They have no pain from it. Not all disc herniations or disc bulges will cause a problem. Some do, some don't, okay? But this is what a nice healthy disc looks like. This, where it's white like that, that means there's a lot of fluid in the disc. That's that middle cushion part that I was talking about. You can see you lost a little bit of that white here, some of that, and you got a little itty bitty bulge right here. That bulge may or may not be causing a problem for this patient, okay? This, you got a disc herniation right there. It's a little bit bigger. There's a decent chance that might be doing something, irritating the nerve and causing some pain. And then you look at this guy, okay, over here on the right-hand side, you can tell the difference between that guy and that herniated disc right there. This is what we would call an extrusion. I bet you that patient is in a lot of pain, okay? That's probably causing some issues, okay? So typically disc herniations or disc bulges will only cause pain if they're irritating the nerve, okay? So they come out, they pinch on a nerve, they sit on the nerve, they make the space too tight for the nerve as they leave the spine or as they travel down the spine. And that's causes the inflammation, causes pain in the back, and oftentimes will cause pain down the leg, which most people will call sciatica. Or if we're talking about the neck, you get pain running down the arm, sometimes with numbness and tingling. Sometimes in more extreme cases, you can even get weakness and muscle loss if the nerve gets pinched and damaged enough, okay? So just a few facts right there. We kind of talked about that a little bit. Okay, so what can we do? There's multiple things that we can do for a disc herniation here, okay? Anti-inflammatory therapies, injections. Let's talk about a few of these. Okay, anti-inflammatories, okay, that's usually what I jump to almost right off the bat, are anti-inflammatories, okay? There are some studies out there that show that when a disc herniates and pinches on a nerve or irritates the nerve, they've done studies that show that there's 500 times more inflammatory markers than we've ever found anywhere else in the human body. It can be an insanely big inflammatory process, okay? So anti-inflammatories can be very beneficial in clearing out that inflammation, which is also very irritating to the nerve itself and takes up space and just adds to the problem. Okay, so what I do, okay, along with medication and helping direct physical therapy and doing order for physical therapy, is I do injections in the back. These are called epidural steroid injections, okay? These are X-ray guided injections. I use a specialized X-ray machine, moves, twists, turns every which way, even takes live imaging so I see things as it happens on a TV screen. And so I can see my needle move, I can see medication going in, I can see all of that on that screen, okay? And that's to help me get the needle into the right spot and to do it safely, okay? So what we do is we take that needle at a little angle and go to that space where the nerve is getting pinched. Once I have my needle in place and I verify that with my X-ray machine, I inject a little dye. If you look at this lower left-hand corner, maybe you can see that there's a little bit of black running through here, wrapped around through here. That's the dye being injected. I inject it, okay, to make sure that the medication is going to go where I want it to, okay? Because wherever that dye goes is where my steroid and medication is going to go. It's going to follow that same path. So if I see it around that disc and that vagal nerve, I know that we got a good injection. I put in that steroid, okay, and we know that we got a good precise injection, okay. So what this does is that steroid, just like the anti-inflammatories that you take in the pill, right, Motrin, ibuprofen, helps disinflame. The steroid does it much better, and it's very targeted, right? When you take a pill, it gets absorbed into your bloodstream. It goes all over the body. This goes right to the source of where the problem is. And we decrease that inflammation, open up that area, and jumpstart that process of trying to get this issue resolved and resolving your pain. Okay. And then usually after I do that, if you're doing well, usually you'll see Dave or one of the other therapists here to really try to work on strengthening the muscles and doing things like that. Okay. Really try to take some pressure off that disc. Okay, see if we can't get things to heal in the back, okay? But that injection really jump starts the process of getting you feeling better. Another thing that I run into, and maybe not so much in Steamboat because you guys are all insanely healthy here, okay? I have worked in medicine in Albuquerque, New Mexico, Las Cruces, New Mexico, Philadelphia, Cleveland, Ohio, Sandusky, Ohio, Dallas, a few surrounding suburbs, Fort Worth, and a few other areas. And I know I'm missing some here, but I've never met a group more healthy than you guys here at Steamboat. So this I don't run into as much, but smoking can really affect the back. Everybody talks about how smoking affects the lungs. Smoking will destroy your spine. Okay. Sometimes I won't even have seen the patient yet. I'll take a look at their MRI before I go in the room, and I already know that they're smoking. And I'll ask my MA, do they smoke? Yeah, they smoke. Okay. So what happens is the chemicals, okay, that are in the tobacco and in the cigarettes, okay, what they do is they weaken that tough ring that surrounds the cushion part of the disc. So it makes it weaker. Also, nicotine affects the blood vessels, so that you don't get the oxygen and nutrients that you need to heal, okay? So I'll tell you patients that smoke, look, you can get the best care in the world from the absolute best doctor in the world, and you're gonna be fighting a losing battle trying to heal your back. If you smoke, you gotta stop smoking, okay? So smoking absolutely affects the back. So moving on a little bit, okay, to another problem area in the back. So disc herniations and pinched nerves is probably the number one thing that I see, okay? That pain running down the arm or that sciatica running down the leg. But also what I see is I see issues with facet joints, okay? We're basically talking about arthritis, okay? Just like any other joint in the body, you can get arthritis in the joints of your back as well. And just like it can hurt your knee, it can hurt your shoulder, it can hurt your hand and fingers, it can hurt in the back quite a bit, okay? So the typical pain that I see in the back with arthritis is pain in the back, doesn't travel down the legs. And it's what I've ended up calling the dishwasher sign. Someone stands at the sink to do their dishes and they go, gosh, after 5 minutes, my back is just killing me. I go sit down. After a minute, it goes away. I rest a little bit, I feel good, I go back up and I finish the dishes. Usually standing in one position, especially if you have to be bent over a little bit and you get that pain across the low back. That is really typical of arthritis in the back, okay? So those are the joints right there. Those are the culprits when we're talking about that type of pain, okay? So you can see in this picture, there's nice spaces in between the bones, right? On those joints where I have those red circles. Take a look at this guy here. There's not a lot of joint space right there. So a lot of times when I see arthritis, not always, but a lot of times it's accompanied with a worn out disc. Okay, you lose that cushion in between the bones. Well, you've lost that spacer. And so it collapsed a little bit. And so you got more compression of those joints. You get more compression of the joints. You start wearing out the cartilage and the cushion in those joints and you start getting arthritis, okay? If it gets bad enough, it gets mad, angry, and inflamed, and then you get the dishwasher sign, okay? So that's what we're talking about there with arthritis, okay? So there's a few different things that we can do with that. Anti-inflammatories is very good. Again, this is an inflammatory process, okay? Lots of inflammation here. Just like you can take anti-inflammatories for your knee arthritis, you can take it for your back arthritis as well. Okay, we can do therapy to try to strengthen the muscles in the back, try to support the spine better, open up those joints, take some pressure off the joints and try to help it that way. We can do injections into those joints, okay? And we can also what are called medial branch blocks and ablations in those joints, okay? We can do these in the neck as well. Again, when I say back, I'm meaning neck and back, okay? So let's talk a little bit about that, okay? So same idea, we're going to use that specialized x-ray machine to guide that needle down into the joint so that we get the injection exactly where we want it. I can see that little joint space here. Here's one here, there's one there, there's one down here. I can see those joint spaces, okay, on x-ray, guide my needle down to that joint and do a steroid injection, okay? Some of you may have heard or have had steroid injections for your knees when you have knee arthritis. Same idea here, except that joint is underneath a couple of inches of muscle and tissue, okay? And I need my x-ray machine to actually make sure that it's getting into the joint, okay? Same idea, I get the needle down in the joint, put in a little bit of dye. If I see it going into the joint, I know my steroid's going into the joint, we got a good injection, okay? So we can do that. Now, sometimes though, those joints get so mad, angry, and arthritic, they can start getting calcified, they can get bone spurs, and you go from a nice open joint like you can see there to back a couple of sides. That joint right there, nobody's sticking a needle in that thing, okay? That joint is closed off. I can try as hard as I can. That needle's probably not going in there, okay? And doing a steroid injection is not going to help you with that, okay? But we have a little workaround, okay, that we do called medial branch blocks and radiofrequency ablations, okay? So off of those major nerves that leave each side in the back and the neck, okay, you have little itty bitty nerves that branch off of that and will go to two joints, okay? And so each of your joints have two nerves that go to them. So what we can do is we can do a medial branch block, okay? There's two different ways to do it. There's one way where we put a little steroid in there and make it last longer, but what I'm going to talk about is the diagnostic block in preparation for an RFA. So when someone comes to me, they have the dishwasher sign, okay? We get the x-rays or the MRI, I see those joints are closed off, I can't do a steroid injection in there. This is what I'm going to talk to them about. What I can do is still using my specialized x-ray machine, guide my needle down to these itty bitty nerves that go to the joints, and I can block them with numbing medicine. Now you may be thinking, well, numbing medicine doesn't last long, and you're right, okay? Numbing medicine that I use lasts maybe 5 to 7 hours, okay? It's a test block, okay? We put some numbing medicine in there, block the function of that nerve, and you go home and you do your normal things, like maybe wash the dishes. And if you go, fuck, that felt great. I stood at the sink, I did all of my dishes, I never had to sit down, I only had a little itty bitty pain. I liked the way that I felt for those 5 to 7 hours. That's a sign that I can go in there with specialized needles that hook up to a machine, okay? And we heat up those needles and we burn those nerves. So you no longer have the nerves going to those joints telling you that you have pain from arthritis. And what I tell my patients is, you don't need those nerves telling you you have pain from arthritis. I already told you you do. okay? All right, so we'll just stop them from telling your brain because you already know that, okay? And we can burn those nerves, and that can cause some pretty long lasting benefit for our patients, okay? So if you imagine only being able to stand at the sink for 2 to 5 minutes, and all of a sudden you can stand and do whatever you need to, it can be pretty life changing, burning these nerves right in through there, okay? Again, using the specialized x-ray machine, make sure we get to the right spot, okay? So that's how we do those ablations. And then, of course, after that, there's usually physical therapy, treating your back right, strengthening your back, strengthening your core, eating the right things, doing the hard work, which I'm sure Dave is going to talk to us about a little bit. Okay, but those are some very common things that I see in the back and some of the common treatments that I do. Are there any questions? Yes. That's a great question. Yeah, so I'll repeat it here, repeat it, so everybody online can hear. The question was, what are the consequences of steroid injections, okay? Because they're, what about bone density and some of these things, okay? So typically when we worry about bone density from steroids and things like that, a lot of times that stems from taking steroid pills, right, over and over again, because the steroid pills go systemic, right? So if somebody has rheumatoid arthritis and they need to be treated with steroids chronically, right, that can cause some issues with bone density. Now, steroid injections can cause some issues. It can wear out the tissue there. It can wear out tendons, joints, cartilage, things like that. There's evidence that steroid can cause some damage, but the evidence shows that if you keep the injections to 3 or less within a 12-month period of time, that risk is minimized, okay? So typically, if I'm doing a steroid injection, I try to minimize it sometimes 3 times a year, but I really would like to get away with 2 times a year or less. But if we have to go 3 times a year, that is perfectly fine. There's very little risk with damaging any of the tissues with the steroid injection, as long as you follow those guidelines. And really, that's the same for the knee, the shoulder, things like that. Usually your orthodox are trying to limit that to 3 times within a year.
Thank you, Dr. Sloan. Let's get, we'll field questions at the end.
Oh, great. Awesome.
Test. There we go. All right, there's me. All right, so I'm sure all of us have had back pain or neck pain at some point in our life. Who's all been to PT for it, or chiropractor, or acupuncture? Show of hands. Successful? Does he give you exercises? Are you still doing them? Right. All right, so here's a few just like statistics. You kind of covered those already there basically. A paper I found last year basically had $200 billion worth of management for back pain, which is a lot of money. And then Gray Cook, he is kind of one of the like, I don't know, very like inspirational like founders for the PT world. He's very big into movement. It's not so much straight like medical, but basically once pain is persistent, it becomes a driver, muscle tone, and tension, compounding the problem with stored motor control. So when you have like back or neck pain, you're not going to be moving correctly. And so that's where PT comes into play after you usually see Dr. Sloan to get that calmed down. So basically it's a good team effort here to like get you moving better. So here's a couple 7 myths of back pain. This is basically driven from Dr. Stuart McGill. He's a professor at Waterloo University of Canada, and he's been doing spinal biomechanical research for about 30 years. So basically, back pain is caused by tight handsprings. I mean, they can play into it, but it's not gonna be the exact cause of it. Laying in bed for, is good for your back pain, which is the absolute wrong thing to do. My daily work at the gym will get rid of my back pain. I think about like, think of your gym workouts, everything that you look at the gym is so this way, right? Bicep curls, bench, squats. So we live in this plane here this way. The back's got to control a lot more than just forward and backward. Yoga and Pilates will completely alleviate all my back pain. It's not a blanket here, right? Because we live in different planes of motion and how things are worked during all those exercises. It just depends on how your system is adapting and responding to those stressors. Stretching is good for back pain. Some yes, some no. But the thing is that each stretch needs to be tailored to each individual. Okay, and having a powerful back is protective. Which let's talk some physics here. Any golfers in the room? Okay. So power is the production of velocity and force. If you have a powerful spine, it can be problematic. If the spine occurs under like high velocity, forces must be low to avoid injury. So Tiger, for example, he had a huge golf swing. He had a bunch of back surgeries, right? So your golf swing is high velocity, but low power. So when you come to a deadlift, if you guys know what that is, you're going down for very controlled, a lot of tension, but very low velocity, if that makes sense. Go back. All right, so age and low back pain. Mostly younger patients are going to have your non-specific strains and sprains and disconnect conductions, like what Slum was saying there. Well, most patients over 65 are going to be more degenerative. And then PT is successful, usually patients get better. Most of them recover within 67% within 6 weeks, and then 89% about 3 months after their back pain. So let's review some anatomy. So here's the back, right? Here's our spine. We got a boatload of muscles that cover this thing. So here's like basically your first layer, okay? Reflect those back on this side here. Here's a deeper layer. And I'll talk even a little more about like how deep these guys go, the importance of all of these muscles, how they work together. All right, so the local system. So think about this. Those ones attach directly to your lumbar spine. So you have your transverse abdominis and your internal oblique, your lumbar multifidus, and then it starts in the erector spinae and the quadratus lumborum. All right, so here's your transverse abdominis. It's like the deepest muscle down there, okay? Basically, it wraps around the entire back like this. Fiber orientation goes like this. It's basically a nice, like, hard canister that when it contracts, it stops shearing forces because it attaches directly onto your spine. Okay, so basically, it's like nature's back belt. So we go a little bit superficial, then you have your internal oblique, which is these guys. If you think about plywood, how it's put together, those bands, they're all alternate like that. Think of that as like this whole area right here. Transverse, interoblique, external oblique, and then of course we have the rectus abdominis, the whole six pack that has no attachment to your lumbar spine. So that really does nothing for you besides look good in the mirror. And so like all this stuff when it comes to here, like back pain can be a chronic problem. All right, so basically you have 400 nerves in your body, and that is about 45 miles of nerves. And then all your nerves are kind of buzzing along each part of the day telling you you're alive, okay? When you've been in chronic pain or it's been longer for like 3 months, basically your threshold for system has been reset a little bit. Like you're more sensitized, so a stimulus that you had before may not be or is as more painful, and that's your brain is saying there's more going on than it is, okay? So it's actually, like your brain is interpreting it as pain. So everybody is sitting next to your neighbors, even though we all look the same, on how our nervous systems respond to pain and how pain is mapped to the brain, it's drastically different. All right, so here's your lumbar multifidus, okay? This is also kind of like where Dr. Slow is getting with those injections here, okay? They go from segment to segment to segment of the spine. And they have the same fiber orientation as that transabdominis that wraps around the entire thing. If you as a therapist or practitioner or chiropractor say, I'm touching your multifidus, they have cut you open or they have magic fingers because there's layers and layers and layers on top of that. All right, so multifidus. So there's also we see atrophy of the multifidus, low back pain, and then abdominal muscle control is associated with low back pain. And then there's been structural changes found in the multifidus fibers. Patients have experienced the back pain for 3 months. And then same thing with the atrophy, we see fatty infiltration on like functional MRI of that multifidus. And the thing is too, that it's not always like recover spontaneously after a bout of back pain. So again, here, kind of review. So the local stabilizers, your multifidi, your inters abdominis, attached right to the spine. They control segmental motion. Okay, so they're tiny. They're not meant to be powerful. They control the position of your spine. And they contract when they all go together there. They basically has like a cylinder effect for your whole like core area to transport force from lower to upper body. And it stabilizes the stiffness and fascial tension. So then also, if you think about your core, right, it's not just here. It's anything between your shoulder and your hip because they all influence one another. If you think back to that very first picture of how many muscles that are on that back. So it's like global, anything that affects the back, but doesn't attach directly to it. So if your rectus abdominis, the six pack, then your external oblique, your quadratus lumborum, which is like on the side here, your psoas, which is your hip flexor, your lats, we should pull down like this, okay? And then this is all just one of these spinal extensors. So these are like torque producing muscles. They're large. They link between the pelvis and the spine, balance external loads. And then when you're contracting, that allows rigidity of the spine. Here's a little anatomy here. So here we got like your hip flexors here, okay? They actually attach onto your lumbar spine. So when you go hip flexion, you're adding shearing forces to that. And then same thing back here. Multiple layers of muscles here that will affect the back. And if one of those is being a pain producer, it's a possibility that's more muscular in nature then, or we treat that PT, otherwise you send off to Dr. Solati. All right, so then a little bit of changing positions here. We started talking like evidence-based practice for PT. It depends on the clinician experience, what the research is saying, as well as what the patient values. So if I have a patient in front of me that comes in for back pain, they've been in the chiro for 3 months with no help whatsoever, they're probably not even thinking about any kind of adjustment. So we go through exercise. We'll do some manual stuff. It's not just like massage, okay? There's also functional dry needling that a few of us do in the clinic, as well as modalities like low-level laser therapy and stem down, calm the nervous system down. All right, so this is just one paper found recently here that basically saying non-pharmacological with exercise, multidisciplinary acupuncture, mindfulness-based stress reduction, tai chi, yoga, motor control, exercise, saying that's all the best for like low back treatment right now. Staying on the conservative side. All right, so then we've been taught to do like spinal manipulation. It can be helpful, but it's also too, we don't just like manip anybody who comes to the door. Basically, there's been a group of researchers in 2002 that they established this. Basically, that if you have symptoms less than 20 or 16 days, this is basically the fear avoidance questionnaire. It's just like an outcome measure that we'll give to patients to say, like, okay, how are you feeling? What's your back today? If you have some motion in the hip that monitors greater than 35 degrees of internal rotation, high mobility of the lumbar spine with testing, and no symptoms past the knee, if we do a certain kind of manipulation, there's a pretty good successful outcome that your back pain will lessen. You can see down here, if 3 of the 5 criteria are met, it's like a 68% chance of success. 4 to 5 or 5 to 5, it's up to about 95 success for reduction in pain. So here's simple positioning that move may put you in. And a couple exercises, what they may look like here. Example, bridge, quadruped arm raise, like a standing lateral press or a side plank clamshell. I mean, so the biggest thing here is that we're trying to improve your movement. I mean, if you're all flared up, nervous system's really kicked up high, you can't move very well, seeing him for an injection to kind of calm things down and then come into PT to move better, that's going to be the ticket here. Okay, so when I say the word of regional independence, you can think about glutes can affect your back, T-spine can affect your low back. Same thing with your neck. So we often have to clear joints above and below to make sure it's not contributing to your back symptoms. You know, trial therapy, and when we have limited success, we have to see those guys associated. Any questions? Or afterwards, yeah. After.
I think we can field some questions right now. I gave Dr. Sladicki a text, so I hope he'll get here, obviously. I would say if it's any of you who are on the table, you don't want him to rush it. So we will field some questions right now if anybody has anything. I think we had somebody early that, yeah. But how's that for exercise? Jogging.
Or straight or back.
There you go.
Yeah.
Okay. I had shots in my back and it lasted for 2 weeks. And I know that I could go and have more done, but what are the chances that this is going to get to be a better long-term pain relief than what I've experienced?
So are we talking about just pain in the back, or are we talking about some of that pain running down the leg? Oh, goodness. Okay. So sometimes it gets a little more complicated when you've already had a surgery, right? Scar tissue, things like that. So if the injection lasted 2 weeks, okay, obviously they hit the right spot because you got better for 2 weeks. Okay. But sometimes that means that the inflammation is just too much out of control for the steroid to handle to give you long lasting benefit. But sometimes what you can do is if you get that injection and you get that inflammation under control, if you hop on to therapy a little bit quicker, sometimes that can get you last longer. But if those types of things don't help, this is kind of the conversation I have with the patient if they come in with 2 weeks benefit, is what I'll tell them, look, we can try a second injection. Maybe it lasts longer, maybe it doesn't. But if you're at that 2 week mark, that's where it gets a little questionable about where we go. And really that's a decision that I make with the patient and just discuss everything. Okay, are we covering you with the right anti-inflammatories that are going to help us well? Is there something else that might be causing your back pain that we're missing? Do we need to do therapy? Or is it time to say these conservative measures are not working and we need to talk to Dr. Sladicki and maybe that you have to do a surgical option? Okay.
I've had, like I said, I started with having the test shots in my back.
Okay.
And then I had ablation,
Okay.
which
Yeah.
did nothing.
Okay.
And at that point, I guess we decided to go ahead and do the back surgery.
Okay.
And after 3 or 4 months, discovered I had a loose screw
Oh, goodness.
and had to have some hardware removed.
Okay.
And now I'm considerably worse than I was before I ever started it. I have severe, muscle spasms and I have sciatica.
Okay.
And I've tried so many medications. I'm not sure where to go with this. I'm doing Celebrex, I'm doing meloxicam, I'm doing gabapentin. I get my most relief usually, from a combination of Tylenol and ibuprofen, but it has to be a lot of it. And then I also tried a couple other over the counters. I move them around because I don't know how much of this to keep taking and when it's not gonna work anymore.
So, I mean, with your big pattern, it would be very individualized plan of care. I mean, if I saw you in clinic, we might get a new MRI, take a look at things, talk about the options, right? There's even some options that we didn't talk about, you know, if surgery is not an option. There's even spinal cord stimulators, okay, which we haven't talked about, okay? Where basically you get a pulse through the spinal cord through a little device that basically knocks out the pain that runs down your leg. And those have gotten better and better and better. Okay, the newer ones are so much better than the old ones. Okay, because you may have known somebody with spinal cord stimulator and they go, maybe it was great at first, but I don't like it. They have gotten better. They have changed. Okay, so there are other treatment options. Okay, but I mean, to be honest with you, to make a good decision on that, it would have to be kind of an individualized plan of care, take a really close look at it, do some examination and come up with a plan. But there are some things that we haven't talked about outside of surgery and injections and physical therapy.
I have two questions, actually. One is, Mr. Green, if you could repeat those, the list of things where you said that were most effective for lower back pain. One of them was Tai Chi. There was a few other ones. I didn't hear them all.
Oh, yeah.
If you spoke about them.
Yeah, here we are. You know, acupuncture, mindfulness-based stress reduction, Tai Chi, yoga, motor control exercise. That's back to PT, progressive relaxation. Biofeedback is basically you're using you're seeing things on the screen to say you control a certain muscle a certain way. The low level laser, and then also when we have like chronic back pain too, it makes us kind of be depressed. So then comes into like cognitive behavior therapy. That's basically all those things here for on the conservative side.
Thank you. The second question I had was for either or both of you. And that's, if I understand correctly, what the doctor was talking about in terms of treatment was mostly symptomatic relief, taking down inflammation, those types of things, or deadening the nerve that you don't need to be giving you that report anymore. And even the things that you're talking about, Dave, in terms of the conditioning and that kind of stuff, this is all sort of responding to this poor situation. My question is really, are there things that we can be doing to prevent more structural things or more things that we can be doing to prevent these issues in the first place? And of course, I know nutrition and don't smoke and that kind of thing, but is there anything else just in terms of movement patterns or behavior or anything that you might recommend to help people avoid this situation in the first place?
Well, I mean, one for staying strong and staying mobile. I mean, as we age, we lose 10% of our muscle mass per decade. I mean, so they quantify that from being 30 to like 60 and then not moving well. I mean, if you're super stiff and you're walking like this, your butt's basically not working anymore. So it's making sure you can move your spine, because with the 3 curves it had, it's meant to move. And that's where, you know, Tyson, sorry.
That's good.
Comes in to help with like actually the mobility here, because that if you don't have the mobility of the spine, it's going to be robbed from somewhere else. Same thing for like a hip arthritis. If you lose hip internal rotation, it can affect the back then too, because the body spine will be like saying, wow, I'm not moving well here. How else can I move differently? And that can also be a pain generator. That kind of makes sense.
I said that.
One more back here. Then we'll get to Mary Beth.
Talk to us more about not laying on the bed thinking it's going to help our back feel better.
Well. I mean, it may help you like that, okay, for the short term, but the more you lay around, the more things atrophy. The stiffer you get. And we said we need to movement, so we need movement here, basically. If you don't move, let's see, that's physics, rolling rock stays in motion, right? So that's the biggest thing, you gotta have comfortable movement here without pain. That's where like the injections and all that can help in, because if you're not moving well, everything else is gonna like try to make compensations. The body's a great compensator. After so long here, it always says, I'm done, I'm way too painful here, I give up. So like, yeah, trying to get the spine, the hips, all that to like move better safely is gonna be one way to like help some muscle stimulation to actually feel it's doing the correct job there for it. Well, how about,
So,
yeah,
question was, any specific exercises that help with the Nordic skate or classic skiing individual athlete?
and this is for what age? Are we say young? All right,
They should be able to hear you as well, so.
okay, all right.
All about the young person.
I mean,
50 and under.
the biggest thing still, like lumbar mobility here, as you're coming through with your skate ski poles of like digging in this, that's a lot of stress in the posterior chain and like the lower lumbar fascia, this whole like thick area here where all they attach. Making sure that when you're pushing off is that your hips are stable, but you have enough ability to push off in the skate pattern without causing extra pain there. Simple things like cat-cow, rocking back into child's pose where you can still have that mobility between your lumbar spine as well as your hips. Where I'll start. 64 and fit, all right.
What would you do there? Same?
Yeah.
Still a young pup he was. Anybody else?
Is it dark? Instead of the bones on top of each other, they're off to the side.
So I mean, we're not gonna be able to change that with therapy. But what we work on is basically your movement patterns and same thing back to with Dr. Sloan to help calm things down. And so you can still move correctly and comfortably between your back and your hip. We can't change your anatomy like that. That's something that's done surgery. Well, we're not gonna correct the actual like the bone alignment or like that anatomy, but we can make your movement patterns and more of the muscles contracting so they all start working together in a better fashion for you. I'm sure you've all heard of like, like get your back cracked. Hear that? You're not getting your spine realigned. That's just a joint popping. Okay, so basically it's an like growth and expansive gas in the joint. There's no realignment. I didn't realign my fingers doing that. So we can't change that anatomy. We can change your movement patterns.
It's Ian McDermott, and he said I probably needed to have another MRI because the disc or the disc were compacted above where the fusion is. So probably need to come see.
You might, we'll take a look at it, so. Yeah, I mean, if you had a couple of surgeries and your discs are wearing out, there's a few different things to do with that, but. Oh, okay,
Well,
yeah,
but it's been like 4 months or
Okay.
5
okay.
since the last one.
But, yeah, I mean, if the injections work, that's a good way to manage it, and maybe try to avoid surgery, but if not, Dr. Sleddick, he does a great job too, so.
Okay.
Okay.
Well, I would like to thank Dave and and right now we have Dr. Slattery, safety out of surgery, patients doing fine.
Yep.
Absolutely, hand it over to you, Dr. Slattery.
Thank you. Thank you. That's a good one. There it is. Hello. Everybody. You all waiting, just finished up surgery. Patient is doing very well, so that's good. So thank you. You want to roll back to the beginning?
You're going forward. Oh, or go back.
Yeah, sorry.
Do I have the ability to go? Where,
I'm trying to get you to the right place.
I'm not touching this. It's automatic.
There you go.
Okay. Thank you. Do I have where do I click? Okay. Why did it go automatic?
It likes to. It's bad.
Thanks, everybody.
Hello, Tom.
I'm Alex Slattery. I work at SOC and I do the surgery side of the spine work. So Dr. Sloan does a lot of the injections as well as Dr. Siegel. And so you've heard from them. So I'll just kind of run through my ideas about surgery in general. I'll try to make it quick, and then if you have questions, we can entertain those. So one of the things that I always encourage patients to think about if you're going to have back surgery or any surgery really is to define your goals, what you're trying to achieve with the operation. Now, in most cases for me, that's some level of pain relief. Most times people have a pinched nerve or something that's causing a lot of pain, and their goal is to have that relief. But the other thing to think about is what do you want to be able to do afterwards? Because that can change the recommended surgery. You know, if you're someone who just wants to be able to get up and walk down the block and not put yourself too much strain, we might do something different than if you're trying to ski the chutes and do backflips on the mountain. So, and so you want to have your own goals in mind, and then also ask your surgeon what his or her goals might be, and make sure that those things are in line. You hear a lot about minimally invasive surgery is the best option, and I would say it's always the best option, but what you really want is the best surgery that can achieve your goals with the least amount of invasiveness. So sometimes that's not a quote minimally invasive surgery. Sometimes you have to do a bigger surgery to fix the entire problem so that you don't have to come back or leave things untreated or leave symptoms behind. So a minimally invasive small incision Band-Aid surgery can work very well in many cases, but sometimes there's a bigger issue and more reconstruction needs to be done. More work needs to be done through a larger incision. You hear a lot of terms in back surgery and in spine surgery. There's a couple of key terms that I think it's helpful to know. One is the laminectomy or laminotomy. This is talking about in the low back, but basically with the laminectomy, you're removing the entire dorsal covering the nerves here. So this bony projection here, if you feel in your own back, those bone protuberances are the spinous processes. And so in laminectomy, you remove that entire piece in order to open up the space for the nerves. Versus the laminotomy, you can make a smaller window in the bone that allows you to take the pressure off the nerves without doing as much muscle dissection or disrupting the normal anatomy as much. And then there's the fusions are often added, and most people have some familiarity with spinal fusion, either yourself or you know someone who's had one. And that's when we have to remove an even more amount of bone or an excess amount of bone and stabilizing structures in the back of the spine, such that if we stop there, the vertebrae can start to shift and translate on each other and become unstable and cause problems. And so we have to fuse those vertebrae together with screws and rods, as you see pictured here. I'll run through, I got a lot of slides here I'm going to run through quickly. There's no secret that spinal fusion has its limitations. It can work very well in the right setting. But most patients that I speak with know somebody or they themselves have had a fusion that has been okay. The results may be not good, maybe not great, maybe bad. Some people have very bad results from fusion. Some people do very well. But when you look at some of the larger studies, there's some interesting things to point out. This was a study just a couple of years ago, where they had 391 patients, about 50% improvement in ODI. That's a measure that we use to determine how much disability someone has related to their low back. So a 50% reduction in your back-related disability. Most people perceive that as a very good amount of relief, but it's still, if you were to think, okay, I'm going to get 50% better, that leaves something to be desired for your results from surgery. This was a really interesting study as well. They had about 400 patients, and they looked at, and they kind of found this by accident, and I think they didn't really mean to find this, but they looked at what factors might help people, what might predict somebody would have the best outcome from a spinal fusion. So they defined that as an ODI percentage less than 20. So minimal back-related disability means you can do most things without much dysfunction because of your low back. Minimal back pain, minimal leg pain. So these people that meet this, what's called minimal symptom state here, would be considered cured of their back disease. They don't really need to see a physician. They might take a Tylenol and Advil, but otherwise they're doing very well. And out of this 400 patients in this study, about 19% of them were at that point at 1 year after surgery. Only about 19-20% of people will be able to achieve true cure of their back disease from a fusion. Now, to be fair, about 75 or 80% of people were better enough that they said they were glad they had the surgery, which is usually what I tell people. About 80% of fusions will say at the end of it, when it's all said and done, they've recovered. I'm better enough that I'm glad I did it. So it's a successful surgery, but they still may have some symptoms. They may need to see Dr. Sloan for injection occasionally, and physical therapy, those kind of things. So they're not completely cured. And part of the problem with fusion is that the spine is a mobile structure, just like the rest of our joints in our body. Every time you stand up and you sit, your low back moves. You can see this picture here on the left. This patient is standing up. Their spine curves upwards like this to accommodate for the pelvis. So that allows you to stand up straight and back curves like this. And then when you sit down, that back flattens out. And so those levels move just like a regular joint. So if you fuse one segment, you'll put strain on the other segments next to it, and that can cause earlier breakdown. So I won't belabor the point here, but you can see this is another study where you look at standing curvature here, sitting, and then the worst is actually slump sitting. So if you sit and slump, then that back really flattens out. So in spine surgery, we often talk about fusing people with a proper amount of lordosis or curvature, which is great if you just spend your life standing. But as soon as you sit down, you need the opposite amount of curvature than what we fused you with. So a fusion is really a non-physiologic state. And you can see in this simulated example, if you fuse these bottom two vertebrae, if you left it like that, the spine would tend to sit back like this. But when you sit down, these other discs are going to have to make up for that. And there's a lot of forces going through that. So that's why fusions can be problematic. This was a patient that I treated with fusion, did very well. But you can see how much when he stands up, this disc wedges open a lot. So there's a lot of movement through here. This is stiff now because it's fused. When he sits down, that flattens out. So every time he stood and sat, that disc was rocking back and forth like this. And sure enough, about 6 months after this surgery, he ruptured that disc, herniated a big piece, you can see here, and had a whole new onset of pain, had to have another surgery for that. So, what are the alternatives to that? We've talked some about that fusion. So right now in the US and actually in the world, there are some alternatives to fusion with what's called an anterior disc replacement. That's this device here. So this is a surgery where we can go through the front, through the abdomen, take out a bad disc and replace it with an artificial disc that moves, so it's not fused. Now that can work very well if your problem is an isolated disc problem, but if you have a lot of pressure on the nerves or what we call stenosis, this option doesn't work so well because we can't get to where the nerves are through the front to open up the space for those. So in all the people that I see in my clinic, roughly 5% at most would be someone who might be able to qualify for this treatment. So while it works very well, it doesn't work very well for a lot of problems that we see. So this, I'll go back, this would be the perfect example of a younger person. Bad disc here at the bottom between L5 and S1. These discs are healthy. There's not much pressure on the nerves. These joints back here, called the facet joints, are healthy. So that's sort of the ideal candidate for that disc replacement surgery. But there's a newer device, and some of you may be familiar with this. We've been working on this here. Steamboat, it's a multi-center study that we've been part of, which is, it's kind of the best of all worlds. We go in through the back, we can take all the pressure off the nerves, we can take out the disc, and then we replace it with this device, which allows for motion. So it's more like a total joint replacement in the low back. And this has a much broader use than the anterior disc replacement that I just showed you. So what this looks like, this is schematic of it. Should have pointed this thing out.
It's moving, but you're not getting the update for some reason.
Okay. So back it up. Yeah, so here's another picture of it, cartoon schematic of it looking from the side and then from the bottom up view. Each segment gets 2 of these implants after we've taken all the pressure off the nerves.
Not sure what we have going on.
So here's a patient that actually I treated here in Steamboat. You can see before surgery, he had a blown disc here. He had had a couple of surgeries and blew the disc out again. And he had lost a lot of that curvature in his low back when he's standing up. And many surgeons, if you're doing a fusion in the setting, you'd end up putting screws here, 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 and here to really trying to get that curvature back. But with treating just the one bad level, you can see that he kind of recorrects his own curvature and he was able to stand up straight without pain. And then when he sits down, it still allows that to move. So that's been a really nice option for people. Now it's going through the FDA trials right now. Here's just some of the 1-year outcomes we've seen from this. People starting in, this is their back-related disability. So they start off severely disabled from their low back surgery or from their low back problem. The blue line is the disc replacement. The red line is fusion. So from 0 to 3 months after surgery, people do about the same in terms of their improvement. Then you can see at about from 3 months to 1 year, the disc replacement patients continue to improve, whereas the fusion patients kind of level off. And we've actually been tracking this out further. And as that time goes on, those start to diverge more, where the fusion patients may have more pain because those other segments start to go bad. And the disc replacement patients continue to improve. So where we are right now with this same schematic of back and leg pain. One other thing I'll point out, that minimal symptom state that I highlighted at the beginning, at 1 year with the fusions, about 20% of patients were in that category. At 1 year with this lumbar disc replacement option, we're almost 60% of patients are in that category. And we're actually up to 2 years now on our data, and we're seeing 75 or 80% of people are in that cured category. So 80% versus 20. The results are looking really good. So just to kind of summate all of that, both patients, when you do fusion or you do this disc replacement, both groups will do pretty well from 0 to 3 months. But as you go out further, when you're able to maintain motion, people tend to do a lot better over the long run. And that's because of not as much force is being placed on the other discs. Things aren't breaking down and your back is moving the way it should. So we just finished this FDA trial in December, which means now there's about a 2-year period where we have to monitor how everybody's doing, how the last patient did the surgery, and then the FDA, they're reviewing the final data, both the safety data and the efficacy data, and then they'll give an FDA approval, hopefully, in a couple of years. I did just learn that I will potentially be able to offer this even before that, however, through what's called a treatment arm of the investigational study. So the FDA may still allow us to do that. Their company that makes the implant is working on that right now.
Yep. They have to be loud, yeah.
And I won't take too much more time for our questions. The same options exist in the neck. We have actually a lot of disc replacement options in the neck. I do primarily cervical disc replacements instead of fusions. Same ideas apply in the neck where you can move that. We had treated 4 patients today with disc replacements in the neck. That works very well. Those are not under investigational. So there's a picture of a neck fusion versus a disc replacement. You can see this patient still able to move their head up and down. Those discs move as they do that. And that allows the same benefits that we just talked about with the motion preservation. So there's a lot of those options already FDA approved. We do those all the time. They're an option for the patient. All right. Went through quick. Questions?
There you go.
Ellen. I was just curious if it's possible to reverse or unfuse and replace it with one of these lumbar joint replacements.
Two-part answer. In the neck, yes, that is possible. If you've had a fusion in the neck, I have had several patients, probably about 15 or 20 patients now, where we take apart the fusion and hand it over to the disc replacement. In the low back, it's a little bit trickier. It depends on how solidly fused it is. So if you had a fusion 20 years ago and it's rock solid, one piece of bone all the way through, pretty much what you have. If you had an attempted fusion that didn't fully fuse or didn't heal all the way and has what's called a pseudoarthrosis, there might be an opportunity to go in and take it apart and change it over to the joint replacement like that. More often than not, the people that would benefit from this treatment who've already had a fusion would be treating next level. So if you had fusion, say, between L4 and L5, and then your disc between L3 and L4 went bad, you could go in and do the joint replacement above the fusion and stop the progression. So rather than doing another fusion surgery. Sure that's probably gonna be most questions.
The last procedure you talked about, the lower back, you see that moving up to the neck.
Which, this procedure here?
The last, yeah.
Yeah. So the answer is no, we don't need this kind of procedure in the neck. The disc replacements we go through the front. And the anatomy is different in the neck than in the low back, such that when we go through the front, we can take out a bad disc. I can also get all the pressure off the nerves and replace that with the discs that we have. So we don't have the need for the full joint replacement like this to go through the back like we do in the low back. So I don't see this happening in the neck for that reason. And also there's some different anatomy with big vertebral arteries on the sides and the nerves are in, but it would be very dangerous in other words to do this in the neck versus the low back. So.
What's the criteria? When do you decide that it might be possible for a replacement as opposed to just a minimal surgery?
That's a great question. So replacement would be when there's more than just one problem. So if you have a bad disc, what's called facet joints, these small joints back here called the facets, and you have a lot of stenosis, and all of those are causing symptoms. Sometimes doing an operation like this to correct all of those at the same time would be beneficial. Now, in another case, if somebody has a small bulging disc and one pinched nerve and pain down one leg, a minimal operation going and just open up the space for that nerve can work very well. The downside of that is that those problems can come back. You can get another disc herniation, for example, at the same level. And if that's happening the second or third time, then you might consider doing something like this to go ahead and treat that entire segment. With this, once you've treated this segment here and it's fused and it's healed in and there's no other, comfort surgery, there should be no other issues at that level anymore. So you're kind of taking care of that as a true problem. But again, that goes back to defining your goals. If your main pain is one leg that's got burning, numbness, and tingling, a small bulging disc and a pinched nerve, that's a great operation to go in and just make a small incision and that space out with minimal surgery.
Anything else? Well, we want to take a minute here and thank our speakers. Happy for our surgical patient is going to recover just well. Just take the time. There's some food back if you want to get that. And as much as we want to thank this, the individuals who helped put this together, we also want to thank you, our audience, and thank you for taking the time coming in here today. Listening to it. We have to say, and hopefully you come back leave here with some really good information, and know that you have an excellent team here with non-operative management, physical therapy, and if we ever get to that point, surgical management. So one of the taglines we like is, with our community partners here, we're partnering for world-class care. Our primary care docs, Dr. Iverson, the hospital here, and SOCI, we're proud to be a part of it. So thank you.
Yeah. Slide. Report orders. Let's do it. I was wondering.
Yeah.
Thank you. Thanks for coming.